Hi everyone. My name is Ria, and I'm a fourth year medical student at Kansas City University. Today, I will be presenting to you all a case presentation that I encountered during my OB/GYN rotation. And the topic of my case presentation is Degenerating Uterine Leiomyoma, a Diagnostic Dilemma. So, just really quick, I'm going to briefly summarize what all a little bit about myself. I know Catherine already covered it all pretty thoroughly. So, on the picture on the very top, the right of the screen is a picture that when we went to a global health trip with school to Kenya last year. Global health is something that I'm very passionate about, and is something that I would encourage each one of my fellow peers to volunteer once at least in their lifetime, because I feel it adds a very unique perspective to your medical practice as a future physician. Then something other that I'm really passionate about is dancing. So you can see in the picture on the left of the top right of the screen is when I choreographed a dance performance with my friends. In the image just below is it when I went to Seattle with my family, and I would recommend the place to anyone who is a big space geek as me. Other than that, during my free times, I'll enjoy watching Big Bang Theory, baking, and trying out new coffee places, with Messenger Cafe in Kansas City being my favorite. So, before I talk about my case presentation, I wanted to briefly review what uterine fibroids are and their different types. So, uterine fibroid is a basically non-cancerous tumor made up of smooth muscle cells of the uterus. Now, these are very common in women of reproductive age group. However, they are rare in women in the postmenopausal age. Depending upon their location, a uterine fibroid can be classified into three types. First is the submucosal, which is when the uterine fibroid is right within the inner lining of the uterus. Next, we have is intramural. These are the uterine fibroids that are within the uterine wall, as you can see here. And lastly, I have is the subserosal. These are the uterine fibroids that are within the outer lining of the uterus. And as you can see here, these fibroids can grow very big in size, as we can see in this fibroid, which is in the subserosal layer and is within the fundus region of the uterus. And as they grow in size, they tend to outstrip their blood supply, because of which they start degenerating. So basically, there are three types of degenerations that can happen in a uterine fibroid. It could be a hyaline degeneration, it could be cystic, or it could be myxoid. Now, degeneration in a uterine fibroid is a very common complication and is seen in about two-thirds of the presenting cases. So now I'm going to briefly talk about all these different types of degeneration and how they present on imaging. So first I have is the hyaline degeneration. It is the most common form of degeneration seen in a uterine fibroid and is seen in about 60% of cases. Herein, there is replacement of the normal muscle cells of the uterus with homogeneous acellular and eosinophilic material. MRI is an imaging modality that most adequately localizes and characterizes the uterine fibroids. So hence, on the images on the right side of the screen are the T1 and T2 sequences of a hyaline degeneration of the fibroid. So the image A is an axial cross section. So that is when the body has been cut into slices from top to bottom. And you can see with the help of the arrow, that is how a hyaline degeneration occurring in a uh, uterine fibroid is seen on the image. So you can see that it is isointense, that is, its signal intensity is similar to the signal intensity of the surrounding tissues like the muscles. Now, below image, the image B is a T2 sequence. T2 sequence, in case of a T2 sequence, the uterine fibroid, which is undergoing hyaline degeneration, shows up as hypointense. So it will emit a signal of intensity lesser than the surrounding signals, as we can see in image B. Also, on both the images, you can see that there is this area surrounding the fibroid which has no signal intensity. So there is no signal that we are getting from that region. So that is basically calcification, and that is commonly seen in case of a chronic hyaline degeneration happening in a uterine fibroid. Sorry. Yeah. Next we have is the cystic degeneration. Cystic degeneration is seen in case about 4% of the fibroids, and this happens when the muscle tissue within the fibroid gets swollen with fluid. So there are these fluid-filled spaces that begin to separate the different muscle cells within the fibroid. So now again, the image A and B are T1 and T2 sequences of the very fibroid. Now, in a T1 sequence, you can see that the signal emitted by the fibroid is hypointense, so it is lesser in intensity as compared to the surrounding tissues. Whereas in image B, which is a T2 sequence, the signal emitted by the fibroid is more, so it is hyperintense as compared to the surrounding tissues emitting signals. Also, a point to be noted is that these image sequences are different than the ones that I presented in the image before, and that is because herein the patient was administered contrast before having taken the images. Sometimes we tend to give contrast because organs that are hypervascular, they tend to come up brighter on the images, which helps us to see them better. Last but not the least, I have the myxoid degeneration. This is the most rare type of degeneration seen in case of a uterine fibroid. And herein there is accumulation of jelly-like hyaluronic acid, which is a polysaccharide within the uterine fibroid. Again, image A and B are T1 and T2 sequence of the very fibroid. So, on a T1 sequence, a myxoid degeneration would present as hypointense. So, either the signal would be lesser than the surrounding signal's intensity, or it would be of the same intensity, as we can see in image A, like the signal of the uterine fibroid is similar intensity to the surrounding muscle tissues we see. In case of image B, that is a T2 sequence, you can see that the signal intensity is higher than the surrounding tissues. And in addition, there is this lamellar, lamellar structures that can be seen within the fibroid. So, one thing to keep in mind with myxoid degeneration is the fact that they can be challenging to confidently identify in imaging, and that is just because the very imaging findings are not specific. So, you can see the similar findings in case of maybe like a uterine myosarcoma or a ovarian cystic mass, something which I will elaborate on later. So now going back to our case, so my case presentation is of a complicated uterine leiomyoma with cystic and myxomatous degeneration resembling large ovarian cystic mass. So a little bit about the patient. So the patient was a 45-year-old perimenopausal female and she presented with complaints of abdominal distension since 6 months. Her review of system was negative for any weight loss, gastrointestinal disturbance, or urinary complaints. Her past medical history was non-significant. Her surgical history was non-significant. As far as for her menstrual history, she reported regular cycles every 28 to 32 days, lasting for 3 to 4 days, and with no history of any abnormal vaginal bleeding. Now, on physical exam, no concerning vital signs were observed. Her cardiovascular and pulmonary exam were also normal with no pertinent positives. Looked at it, when evaluating her gastrointestinal system, we noticed distended abdomen with tense dilated veins. Pelvic mass was felt at the epigastric level at about 36 weeks. As for her pelvic examination, high up cervix was observed with flushed vagina. Bilateral fornices were found to be full. Uterine size could not be appreciated separately from the mass. And since we are concerned about an abdominal pelvic mass, an ultrasound was ordered as a part of the diagnostic workup. On the image on the right of the screen is the very ultrasound image that we obtained. So as you can see, there is this one big mass measuring about 21 to 13.5 centimeter, and within this very mass there is these multiple cystic lesions that can be observed, and each of them tends to be separated by a septa. Again, left ovary was visualized. It was found to be normal in shape and size. However, right ovary could not be visualized, something to keep in mind. Then, since the patient presented with this relatively recent onset of abdominal pain, and then we are observing an abdominal pelvic mass on the ultrasound, there was the differential diagnosis at this point included maybe a ovarian cyst, an ovarian tumor, or maybe a uterine tumor or a uterine fibroid. As a result, tumor markers were evaluated. LDH, AFP, CA 19.9, CEF were all found to be within normal limits. However, her CA 125 was found to be elevated. Concerned about the possible etiology of the mass and possibly it being malignancy, an MRI was ordered. So, presented are the MRI findings from the very patient. These both are axial cross section. So, again, we are looking from top to bottom. And as we can see, particularly better on the image on the right, there is this big mass within the pelvic region, and within that mass, there are these cystic masses that can be seen. And each of these cysts seems to have its own very septa. So now, now for the assessment and treatment, considering the patient's clinical history, her ultrasound and MRI findings of a large multiloculated cystic lesion and a CA-125 level elevated, a working diagnosis of right ovarian cystoadenoma was made. Considering ovarian cystoadenoma are some of the most common abdominal pelvic pathologies seen within the woman of reproductive age group. The plan of care was to have the patient undergo right ovarian cystectomy. So that involves taking out the very cystic lesion while preserving the right ovary. However, in the very beginning of the presentation, I talked to you all about uterine myomas and their various forms of degeneration. Only in the end to talk to you about ovarian cystic tumor, that does not add up. And that is because during the procedure, when the surgeon and the gynecologist they were trying to excise the very mass, they found that the lower end of the mass was actually originating from the fundus of the uterus, which you can see in the post-op image on the left-hand side of the screen. This very world appearance of the mass is characteristic of a uterine leiomyoma. Further workup done by labs actually confirmed that the mass was actually a degenerating uterine leiomyoma and not an ovarian cystoadenoma. In fact, the very arrows in the white point to both the ovaries in the patient which were found to be normal. So, wrapping up, some of the teaching points from this case were that a uterine leiomyoma are benign, smooth muscle tumors that outstrip their blood supply as they grow in size. Their clinical presentation can be similar to any abdominal pelvic mass. Third, there are three types of fibroid degeneration and each has its own characteristic image findings. And lastly, even though the degeneration of a uterine leiomyoma is a rare phenomenon, it is important to keep it in the differential diagnosis, especially when evaluating a pelvic mass, as it can be very helpful for the surgeon and gynecologist as they are planning their procedures. In case of our patient, no intra or post-op complications were found or observed. And these are my references. Thank you for paying attention to my presentation. Let me know if you have any questions.